Well, for decades, really, when patients with melanoma were found to have a positive sentinel node, they routinely were advised to go on to completion lymph node dissection. Interestingly, in practice, this only happened about half of the time. We're not quite sure why. There was not really any evidence to support this, but it was clinical practice. Recently, two prospective randomized clinical trials, one an international trial and the other one a German trial, concluded that virtually all of the clinically important endpoints were similar whether a patient with a positive sentinel node had a completion lymph node dissection or not. Given the fact that there's significant side effects associated with completion lymph node dissection, this leads one to believe that or recommend that the preferred pathway for patients with a positive sentinel node is observation. A certain percentage of those patients, somewhere between 5 and 15%, will in follow-up develop lymph node recurrence only. And those patients we do recommend a delayed therapeutic lymph node dissection for. The remainder of the patients actually recur initially outside of the lymph node basin, and in those patients it's pretty clear that immediate completion lymph node dissection would have made no difference. This, I think, is these two trials, and they're very consistent results in terms of no difference in either distant metastasis-free or melanoma-specific survival associated with more surgery, I think should be construed as practice-changing. And I say that with full awareness of how difficult it is to change practice. I heard discussed at a meeting last month a poll of practice in the UK where nearly 50% of people said that the results of this trial would not change their practice. And I think this speaks to the real challenge of disseminating information and changing clinical practice in medicine, and particularly in surgery, a field that tends to be pretty conservative in terms of change. But I think at the end of the day, the absolute consistency of these two prospective randomized clinical trials leaves very little doubt that immediate completion lymph node dissection for melanoma patients with a positive sentinel node is no longer the preferred pathway to pursue. Both trials examined the whole issue of whether there were predictors of who should and should not have an immediate completion lymph node dissection. And interestingly, both trials were, again, remarkably consistent in demonstrating that there were no predictors of who might and might not benefit from or particularly who might benefit from immediate completion lymph node dissection. We'd long used a criteria for recommending lymph node dissection as significant tumor in the sentinel nodes, either tumor burden, largest size of tumor, or multiple lymph nodes involved. Neither of these prospective studies suggested that those patients had derived any benefit from immediate completion lymph node dissection. The one other point I did want to make is that one of the concerns about omitting completion lymph node dissection is the fact that there is some prognostic information that can be derived from the status of the non-sentinel lymph nodes. And without completion lymph node dissection, it becomes a little bit more challenging to risk stratify those patients into those at high risk for recurrence who might be eligible for adjuvant therapy. There's a general movement right now across the melanoma community to develop effective risk stratification criteria that will be functional and informative without the information provided by the non-sentinel lymph node status. And so I think we're going to move past the prognostic value of completion lymph node dissection and recognize that where it has little therapeutic value, little if any therapeutic value, it's just too expensive a piece of information to insist on for prognostic information. We're going to find alternative ways to get that information.